So our patient today is Dr. Swiss patient from Montreal, and she's Eastern European kind of ancestry genetics. She's a septuagenarian, which means she's in her 60s.
Both divorced.
60 to 70, and we just met a few minutes ago, and you can tell just a few little things about her face. She's had a rhinoplasty, so she had one rhinoplasty when she's 40.
30.
She's 30, and in her 40s she had upper blepharoplasty and a lower blepharoplasty. So that's the two things she's had done, right? And she's had a little filler, a little Botox in the past.
No Botox.
No Botox, just a little filler. When was her last filler, Doc? Arthur?
About a year ago.
About a year ago? Okay. So the best thing about her is she's artsy. She paints. She's a watercolorer. So because I paint and draw, and I find patients that are visual make a much better patient because they have a better eye. It doesn't make you smarter, although she might be quite smart, but it makes you more visual. So if you're a visual person, then you can usually see those things that happen to us over a lifetime. Do we have a mirror there, Lorraine? Up here? We could maybe find one somewhere. So faces are, as we've all learned, faces are all about genetics, and genetics is all about biology, biology is all about physics, and eventually comes down to mathematics. So faces are all about math, as we've been discussing. So without a mirror, she won't see what I'm doing here, but it looks like I'm going to stick you here, but I won't. Just keep your eyes open. So that, for the camera to see, will maybe go up a little bit. That distance between the eyes, we've been talking repeatedly. We sound like we're a broken record here. But that distance between the eyes stays the same from basically from 19 to 100. And remember, the first 100 years are the worst. So that distance between the eyes stays the same. So that should be the distance between the brows, between the head of the brows. So you can hold that mirror. Which one's the magnifier? I hate that one. I usually mark that out with black. So you can just kind of put that down for a minute because you'll interfere with the camera. So that distance should be the distance between the brows. The head of the brow should be lined up with the inner canthus, and that distance should be the width of the nose and the maximum volume of the lower lip. So we've talked a little bit about that. And then the other side, the phi, the 1.618, because this is that basic measurement you use for all your measurements of the face, should be the length of the eyebrow. And even though our eyebrows are a little sparse, you probably plucked your eyebrows when you were younger, right?
Yes.
Yes. That would be a yes. So what's happening is the eyebrow structure, even in repose mode, because of dynamic discord, scowl for me a little bit. Scowl. And she's pulling this brow over and down. She's got biceps over here. And these are pulling. And with time now, the actual eyebrow is below the bony prominence here, the orbital promontory. So the brow should be here. But it's pulled down. So that length of the brow should be here. And the tail of the brow should be lined up with the corner of the angle of the nose to the corner of the eye. The length of the brow should be the length of the nose. And you can do it several ways. I like to do it from the crease. Open your eyes here. From the supratarsal fold is a good way to the tip of the nose. And her nose, because of the rhinoplasty and genetics and age, is a little wonky. It's not a bad thing, but there's ways you can do to just harmonize that and balance it out. So the length of the brow technically should be the height of her forehead. And her forehead's a little high, right? So you wear your hair up or down? Bangs. So her brain just intuitively tells her to wear her hair down because she knows that it just doesn't balance well with her hair all the way back. She won't like that. Her eye just doesn't like it, so she'll wear bangs. So the length of the brow should be the width of her lips. And what happens as we implode, as we deflate and we retrude, sit up here for me a minute. That's good. This whole corner of the mouth sinks in. Now we all sink, sag, and wrinkle. It's part of the plan here on Earth. If you don't want that, you got to go to Venus. So here she sinks more than she should. That's why this is all imploding here. So she's more of a wrinkler and a sinker, not a sagger. So this jaw angle is beautiful, and her cheekbones are great. And her smile, she knows her smile is fantastic. So that should be the width of her lips. And the chin is kind of recessed here. It's giving her you can see her pointy chin. She's getting this little witch's chin here that most patients get, so they just like. They don't know why they don't like it, but it just gets so she doesn't like it. So it's all, and what we try to do, of course, is try to recreate in a sort of a biomimicking way what she looked like, say, 10 years ago. So if you look with each side of the face, even though the driver's side generally gets more wrinkles, she's got more creases on this side, so you probably sleep on this side, the right side, correct? Yeah, so you just have to be a little bit of a Sherlock Holmes here. So it doesn't take a lot to figure out that she sleeps on her right side. You sleep on a rock or a pillow? So when she smiles, if you get her to spontaneously smile, she's got a bit of a gummy smile, but not enough to really address that too much. So that's kind of my basic measurements, Doc. So
Great. So away we go, because we want to go ahead and start sticking needles in people today, don't we? Ilona, it's great.
Good at it.
I'm so good at it.
And then what I do is usually draw out exactly a plan and draw out each side of the face
Sliding
kind of
down a
thing and start from there.
Can we get another of these? Actually, why don't we take
a towel or something? There's actually a pillow here, Arthur.
Like that?
One other pillow under here? Here, let's get a pillow here. Let's put that.
She's good.
I'm really good.
Oh, I know you're good.
So we're going to clean her up. I'm going to make Ilona nervous because I'm going to tell her that I'm going to be the hands, but the audience is going to be the brains. Okay, so looking at her face, upper third, middle third, lower third. Give me a score for her upper third, guys. What is it? 6, I heard. Give me a score for her middle third. 7. Give me a score for her lower third. 4. Give me a score for around her eyes. 4 or 5. Okay, so if you only had a limited amount of product, where are you going to concentrate? Eyes and lower third. Perfect. But we don't have a limited amount of product. That's why she's so happy. Right. Okay. So let's look at her forehead. You're holding a syringe. 3 things you can treat. Lines, contour, and feature. We just heard everything go through it with Kent. So let's talk about, we're going to do fillers now, so let's talk about treating the contour. We're also going to treat some of the lines, and we're going to treat her brows as well, if she's going to allow us to. So I'm going to turn your head just a little bit sideways, Ilona. What do you think about the contour? Does she need a little bit of stuff over there, guys? Yes or no? Okay, fine. What are we going to use? A product that spreads or a product that lifts? Spreads. What kind of product are we going to use? We're using the Allergan products today. So.
Vollift.
Vollift, which you guys don't have.
I don't have it.
Okay. Volure, which you guys don't have as well. So we could use what I'm going to use actually on her forehead. I would use Ultra. Okay. And I would blend it down a little bit. We have to assess the type of skin that she has over here.
1 to a quarter, 1 to a half.
Oh, probably like 1 to half, yeah. So what she has over here, as I was saying, is a little contour deficiency. So we're going to go after that. We're also going to do a little teeny bit of temple work because I'm going to try to symmetrize her eyebrows. Okay. So remember, as we age, hollowing in the temples, flattening of the lower forehead, increased convexity of the upper forehead. So we can look for these things. We'll find them. Excellent area to treat with filler because toxin will drop her brow, and we certainly don't want to do that. And I don't think I've ever done any Botox on you, have I? No. So we're going to get to that in a second because they're going to prepare it, but I'm going to move on. I'm going to do a little bit of brow work on or temporal work on her. Even though she's fairly flat over here, I want to take out a little bit of the harshness of the corner of the brow. Remember, we don't like to see sharp angles of bones in women for most parts. We like to see that gentle S-curve, the OG curve. We like to see it on their bodies. We like to see it on their faces. So we want to soften that up a little bit. So I'm going to ask for my prepared Voluma that I have over here. There's one right here. I'm going to take out a little cleanser. I'm going to take some pads that I have over here. I'm going to put the pads on her shoulders. You can see that she's wearing little shoulder straps over here. This happens about 1 month of the year in Montreal because the rest of the time we're wearing overcoats. So I like to go ahead and I tuck them in like that. So if you ever come to Montreal during the summer, you see people walking down the street and a nurse chasing them, it's because I forgot to remove the pads, okay? They have these little epaulets. I'm going to clean, and you guys are going to direct me. I'm going to do a single injection point over here. I have a 30-gauge needle loaded onto Voluma. Voluma is now Champagne Voluma. If you want to take a look, you can see that there are actually, if I get a proper background for this, you can actually see, as he focuses in a little bit, that there are tiny, tiny, tiny little bubbles over there because I've wetted down the Voluma a little bit on her because she is thin-skinned to me. Okay? A little bit of a sun worshiper in the past and maybe in the present too. And so she's actually thinned out her skin a little bit. I do want to have a very robust product, but I love the way this product works. So this is just what I did in her case. So where am I going, guys? I'm going where? 1 centimeter up and then 1 centimeter over, right? So we're going to parallel over here. I'm looking. She has a vein over here. I put my finger to see if she has a pulse. I know that she's got a pulse, but not one right here. In fact, I can feel it back over here. So I know that I'm okay over here. I stabilize my hand. I go in as a vertical injection. Here's the temporal crest so you guys understand where I am. It's 1 up, 1 over, a little pinch, Alona, and I'm down on bone. Okay? Look at the depth that I'm in out over here. I put my finger behind my injection so that it doesn't go up into her forehead, and I'm very slowly advancing the product. And the rheology of these products, as you can see, look at my plunger. I could fire this in about 3 seconds, but I don't want to. She doesn't need a whole bunch, but I'm going to put in probably about 0.2, 0.25, but I'm not looking at my syringe. I'm not looking at a steering wheel, like I said, when I'm driving. I'm looking at the street. So I'm looking at what I'm doing over here and then very quickly checking over to the glabella region to make sure that I don't see any blanching in that area. There I am. I'm finished. Now I take the pad that's on her shoulder. I have my pad ready in the event that I did skewer a vessel. I'm not going to be in it because we said on the bone over here by the anatomy there is very little vascularity. I'm going to remove my needle. She didn't have any bleeding at all. And I've got to tell you that she has a platelet issue. She has a high number of platelets. She takes medication to drop her platelets and aspirin to keep her blood thin. So I wanted her up here. What do I do differently that I would do in a patient who isn't on blood thinners? If you can control blood thinners in your office, great. If you have a patient that you say, listen, you're going to go ahead and have a treatment done, it'd be nice if you stopped your aspirin a week before, that's fine. But a lot of times you don't have that luxury. It's the homeopathy that scares me more than anything else. What I'm going to do here is I'm going to switch to small needles. I'm going to use cannulas. I'm going to keep pressure on. And we have an ice pack over here ready as well. Ice packs do not stop bleeding. If you give a patient an ice pack because there's bleeding, ice packs hurt. They'll hover over the area and they'll bleed underneath it. It's pressure. When you go get a blood test at the hospital, they give you pressure, not an ice pack for your arm. And then ice packs are there afterwards to limit the amount of bruising and to decrease the swelling. Okay, so we're going to hold a little pressure here, just maybe a little bit longer than usual. The product really blends in quite nicely. Open your eyes for me. And look at how we elevated a little bit of the tail of the brow, just like that. And we're getting just a little teeny bit of elevation over here with a little bit of flatness. I've got to look up to this camera, I guess, is where we're at. And there we go. Okay? Perfect. That's temple injections. We're going to move on. Do we have the other stuff blended already?
Yeah. Do you want to do the other side? We're ready with this, though. If you
okay. Yeah, if we're ready for this, I'll continue on this side so we can see the hemiface comparison. So I'm going to use Ultra. They have Ultra Plus over here. I might very well use Volbella. If I had Volbella over here, I think they ran out to get me some.
We've got Volbella.
Do you?
Yeah.
Where's that?
Right there.
Where?
Right here.
Perfect. That's what I want to use.
Okay. Do you want to use it straight up?
Oh, 50-50. I'm sorry. As far as the preparation goes, because you guys want to understand that, here's an idea of what we use, okay? Again, this is complete off-label. It's nothing that the company would really want to promote. I'm going to have this in front of your face here, Alona. This is a little Luer lock to Luer lock connector. It's made by a company called Baxa, B-A-X-A. I was stupid because when I started blending back in 2007, I had to search the internet to try to find something that I could use because it was normally a 3-way stopcock, which is what they have over here, but they're messy. This one is a female-to-female Luer lock adapter. See that? Okay. So I should have told the company, listen, I got an idea and I think it's going to run with it because everybody's ordering these things like crazy. They come individually packaged, sterile. I open one up like this. I put a little V on it for Voluma, and that stays my little connector like for Voluma during the day. Okay? Beautiful. There it is. Yeah. Here we go. Okay. So this is what it is here. I connect it to a 3 cc syringe, like this. Okay? I take 1 cc of Voluma. Actually, the way you do it is you connect it to the Voluma first. You do 1 cc of Voluma, and then you prime it by getting rid of the little air that's in the actual connector, by gently getting a little bit of that meniscus over there. You see the way it pops up? There's the stuff. Perfect. Then you connect it to the 3cc, and you put the entire 1cc of Voluma in. I then take a second syringe of Voluma and do the same thing. I now have 2 cc's in here. Are you following me with this, guys? Okay. I take my 3cc syringe, another one, a fresh one, and I drop 1 cc of lidocaine. Most of it lidocaine without epinephrine, a teeny little bit with epi. We just did it before. 0.8, I'm drawing up 0.1, only 1 cc. So 0.8 or 0.9 will be on that 3cc syringe, 0.8 or 0.9 of lidocaine without epi, and then maybe just a 0.1 with. Because I don't want a lot of epinephrine. I want enough to cause vasoconstriction on her because of the fact that she's on blood thinners, but I don't want to cause her to have, look at the eyebrow now. And I don't want to cause problems. I don't want to cause blanching so that she ends up having a block for 4 hours and then she feels like she's been at the dentist. Not that I have anything against dentists, but you don't want to sort of not, always have to make these excuses. I can't move my mouth, or I went to the dentist, half my face is white from the anesthetic.
Can you use normal saline?
You can. Why do I use lidocaine? Because the preservative in lidocaine for me is better than the preservative that comes in most saline. Saline's benzyl alcohol. We have that also in the lidocaine, but the lidocaine is a little bit acidic in order to be able to accommodate the adrenaline or whatever that's in there when you do that. And so I find that it's a little bit less, it's a little more bacteriostatic. Not bactericidal, but bacteriostatic. Because doing this type of thing is not recommended because you can contaminate if you don't take care, right? And then I go back and forth. So the 1 goes into the 2 and becomes 3, and it goes 3, 3, 3, 3, 3 back and forth, and I get the entire 3 cc's.
Obella.
Thank you. I get the entire 3 cc's into one 3 cc syringe, and I retrofill again the initial 2 syringes of Voluma that are now empty, plus 2 more Luer-Lok syringes to 0.75 times 4 makes 3 cc's. I now approach the patient with 4 syringes instead of 2. But I don't charge per syringe anyways. I'm charging for the result. Okay? So here we go. So I'm going to go ahead and use this. Oh, I don't want this needle.
This is straight up Bobella.
Okay, so let me have it on
a
30 gauge, please.
Well, that's essentially a 30 gauge.
Okay? You have a 30 gauge needle? Put it right over here. Actually, retrofit it into one of these guys, okay? Give it to me on a BD2. So I'm going to inject now into the forehead. We're going to go from temporal crest to temporal crest across the bottom part of the forehead where she's mostly lined. You can see most of the lines are down here. When we activate our frontalis, raise your eyebrows up for me, please. Look at how most of her lines are down low, very few lines up above, but it's an occipital frontalis. It's actually originating from back here, but most of the excursion is here, which is why that little zone over here, if you go in with toxin, you're going to drop her eyebrows, and we want to try to elevate her eyebrows. So I'm going to use decanting it into a BD2 because anytime I work around the eyes, I like to get that syringe on the thenar eminence so that I can control with a squeeze rather than a push. This is all reviewing what we did yesterday. And you'll see as she's backloading the stuff, and this is a very thin product. Perfect. You can see that as I'm going over here, come in a little closer if you don't mind with the camera. And that would be fine. Watch the tip of the syringe. That's good. I'm just barely squeezing on the syringe, and you can start to see the product appearing. Can you see that at all? I can see it from here. Here comes the product. Yeah, and I can make it look bigger and bigger and bigger. How can you hang a drop and make it bigger and bigger like that? Look, the drop hasn't dropped yet. I can't do that with a 30 gauge. I can't do that with a big needle, but I can do it by squeezing the trigger. Look at that. Still hasn't dropped yet. Okay? So, here I go. We're going to treat from here to here. Can I go 1 centimeter medial to the temporal crest? Yes or no? What's the answer? Going to hurt her, right? You want me to start taking my clothes off? Is that the story? Story is 1 centimeter medial to the medial crest, the temporal crest, is where the deep branch of the orbital nerve is going to be, the supraorbital nerve. And if I go there, even though she's a little bit depressed here, if I go there, she'll say possibly, ouch, and feel the pain back here. So I'm going to go a little more medial to it. Am I going superficial or deep? Thank you, guys. Here's my little deep injection. Do you see that needle is all the way in? Did I hurt you at all there, Alana?
It killed me.
It killed you. Thank you. That's Montreal humor. And I'm going to start slowly to go ahead and inject. Okay? What am I looking at? I'm looking at the skin. Checking the skin, checking the glabella, checking the skin area. I'm injecting very, very slowly. You can see the plunger barely moving at all. Okay, I'm going to put in a little more than what I would normally do, which means I'm going to put in about 0.05 or so. Now I'm prepared in case I skewered a vessel. I'm going to prepare, which I didn't. And then I take the product and we just gently mold it over. And that is forehead injections. We did this yesterday. I'm going to continue along over here. And I'm just going to fire in. Look how I have my pad waiting for me. In the event that I catch a little blood vessel and there's a drop of blood. Okay. She's doing. This is Volbella, pure and simple. Okay. Because your skin is a little bit thinner. There we go. Her skin is a little bit thinner. And typically when you backload these things, you backload them to about 0.15. Okay. 0.15. That's what he gave me. 0.15. And that's usually enough for half of forehead. So use about 0.3 for the forehead. In most patients, but some patients who have a little bit of if it's a patient, for example, who is a male with a really, like we had yesterday, I would use Ultra or Ultra Plus to do this, okay? And you can still inject those if you want through a BD2, but they work well through a 30 gauge as well. So we haven't caused any bleeding or anything specific on her because I'm using, again, in somebody who has, here's my temporal crest, I'm okay over here. I'm going to give her just one last little blast right there. There we go. And we're going to move it over. Okay? If I've gone through a branch of the supraorbital supratrochlear, I have to be behind it. You have to feel the bone. That's why that needle now is dull. And I can feel the difference. It starts to barb a little bit. You can actually hear a little, what she probably hears as I'm going through. Okay? So, we now take a look. We'll keep just a teeny little pressure because of the fact that she's on those blood thinners. She stopped her aspirin about, 2-3 days ago, but it's not going to make a difference because that stuff is in your system for a good 7 to 10 days. So she's trying to keep her platelets from being too high, so she's taking a medication to drop her platelets. She doesn't want her platelets to be too sticky, so she's using aspirin. And then she came in to be on stage. That's why she likes me.
No, I just love you.
That's right. There's no like. It's all love.
Pure.
Okay, so now we're going to look over here. The thing that you see right off the bat, raise your eyebrows, is she can still move her eyebrows beautifully. Relax now, please. And if we have her relax just a little bit, and she takes a look, you can see that the line over here is much more evident than here. You actually efface the lines here very, very slightly by doing that, okay? We're going to move on. Any questions? Good. We're going to go on to the cheek now. When we look at the cheek, can I have a marking pencil? We take a look at the cheek and say, what does the cheek want? What is the cheek telling us that it wants us to do? I have a white one right here, it looks like. Do we have a little, we don't have a, do we have a, what's it called? A sharpener. That's the word. He does.
Yeah.
Of course he does. He's also got some lures in there that are unbelievable for fly fishing. That he makes himself, I'm sure.
Don't use lures for fly fishing.
There you go. You see how much I know about fishing.
Those are spoon chuckers.
Oh, there you go. That's
Right? Well, no, not lures. They're flies.
They're flies, yeah. That's what they are. Okay. So if I take a look at her face over here, and I turn her at all 3 quarters. Remember, guys, you can turn the patient's face. You can see that she has a little wonkle or a little waggle over here. So she's missing some volume over here. I'll draw that out.
Volbella.
That's Volbella.
Certainly, we can see that she's missing something over here, then a tear trough, and maybe coming down a little bit like this. Okay? Here we go. Anywhere else that we see? Maybe a little bit of lateral canthal region over here. We'll mark it out. This is what the face is telling us it wants. We're going to move her a little bit. And certainly, this is what she complained about at the same time, is that, as Kent mentioned, she's a sinker more than she is a sagger. And we're going to see this area over here. These are the tough areas. The submalar region is the tough area to treat. We wanted a challenge today, so we're going to do that. Okay. So what do? I draw a line. Open your eyes, please, Elena. Look straight ahead into the camera right there that's above you. And I draw a line out of her, sort of paralleling her, if I can get it to right, there, the outside of the iris, okay? It's a little bit medial, but that's fine. Why do I do that? Because this is Asian, this is a Caucasian country, this is Asian country. This is safe, this is more dangerous. I know that in this area I can inject what? What depth? Both. Beautiful. Okay, so let's start with that. Let me have the Voluma, please, on her. No, I have all my stuff over here.
Right here.
Yep.
Voluma's right here.
I'm using everything blended on her because her skin is thin.
This is Voluma.
Great. A little cleansing over here. And here we go.
Blend.
I'm going to turn your head slightly towards me. Okay? You can close your eyes, keep them open, whatever you like. You can sing to me. Here we go. Small little stick. I'm down on bone. I'm injecting very, very slowly. I'm then releasing off a bone and lifting. And I'm putting in a bolus of probably 0.1. No more than that. Just like that. And then tapping. She's behaving herself so far with her blood thinners. Okay? You usually behave. Yes, yeah, you do. All Canadians behave. We're the most apologetic people in the world. There was a study that showed that. They actually took 1,000 university students, put them on the streets, and had them bumping into people. And Canadians, when the student was the one who bumped into them, Canadians would apologize. We're just the most apologetic. That's what they found. Another little injection over here. I chose the high point first because I'm working my way down. Here's my second injection down on bone. Relax, release, lift. Again, not more than 0.1 in her situation over here. And my last injection is going to be down over here. Inject, release, and lift. Okay? There we go. Say it loud. It's blended. Blended 1/3. So 2 cc's of Voluma with 1 cc of lidocaine. And the lidocaine has just a little teeny bit of epinephrine in it. I'm going to hold a little pressure. How are you doing? You want water? You need something for your back? You let me know. So far, so good. That's what the guy said when he fell off the roof of the building as he passed the 10th floor. So far, so good. Until you hit the ground, everything is great. Good. Okay. Now we're going to take a look. We're going to see if we've started to create that little bit of an OG curve over here. She still looks like she can need a little bit more. Let me have, again, the same syringe, please. And perhaps with a fresh 30-gauge needle on it, because I don't want to barb her at all. She will bruise with a barb on the needle. I'm now getting below the maxillary border here. I can feel the border of her bone. So when I inject over here, what's my depth over here? Thank you. See, simple as that. That's injection anatomy, because all the danger is deep. Perfect. Excellent. So we're going to give her a little bolus over here. So my needle's only going to go in about halfway. See that? I'm going to lift the tissue like Ken showed us over here. I'm going to put in a small bolus of 0.05 maybe, 0.1, and release. That's it. Okay? Gentle, gentle, gentle. I see people, the first time that I went to do some training on the Far East, coming at the patient like this. I said, whoa, what's going on here? It's okay, it's my boyfriend. I said, not okay.
Ex-boyfriend.
Ex-boyfriend is right. Okay. Very good. Before I get to the tear trough, which I leave to do last when I do patients, because that makes them a little skittish when you're working around the eye, I'm going to do this part of the face over here, which is the submalar region over here, which you can see is a situation of not only volume loss, but she has no support here. You'll find this, in patients, some patients, that's the way that they mature. And certainly in patients who've had a lot of dental work done and have had teeth removed where they lose the trophic effect of the teeth on the maxilla or the mandible, they start to recede over there and they end up needing some support. So what we're going to do over here, she's trying to bruise on me, but I won't let you, is I have just a teeny little bit left, so I might as well get rid of that teeny little bit and I'll put it right next to my bruise.
Now, remember, there's 15 ways to tie your tennis shoes. So there's different ways of doing these little creases and lines. Another way is to do a cannula, like a 25 gauge cannula, and still a blend, but break them up like spokes on a wheel, and break them up along with what he's doing there. So there's another way to tie your shoes.
So I've used so far 0.75. Let's keep a close record of the volume that I'm using on here. I've used 0.75 of Voluma. I used one syringe of 0.75, of which 1/3 was. So how much product have I used? Half a cc of product so far, correct? Good.
Oh.
Can I have the 27 gauge needle, please?
27 gauge needle? What size of cannula do you want?
27 gauge as well. Yes, please.
That's perfect. So that's the cannula.
And that's a very good question. It affects two things in the product, and probably more. But when I did this, when I started doing, the reason I started blending was because of the fact we got the product originally without any lidocaine in it. So I was adding lidocaine in, very similar to what we were doing with Radiesse. So I was blending lidocaine in. The question was, how much do you blend in? And so I started using different blends to see. I came up with two final blends that I like to use when I'm using a blended product. Blend number 1 is 1:2, so it's 1/3 like I did over here. Blend number 2 is 50-50, equal blends. Because when I did it, I did half face comparisons. I was doing the face with Voluma normally on one side and with the Voluma blended down 1/3 on the opposite side. Voluma typically in my practice can last years. I mean, it can last 2-3 years, but I would say on average, I tell the patients that you should expect somewhere around 1.5 years result. When I use the blended product, I found that on average, it was 2 months short of that. It was around 16 months or so instead of 18. And to be honest, for the 2-month difference, the patient doesn't feel it and I don't feel it either. So I'll use the blended product. But now I have Volift. You guys don't, but you're getting it as Volure. You won't have to blend when you have the Volure because it's already not exactly blended down Voluma because there's a difference in the way that they compose the free HA with whether it's short chain or long chain. There's a difference in it. It's not exactly the same, but it will act like that. So what I'm going to do now, and I would normally use about a 50-50 on her, but I have it already prepared at 1:2, is a small little stick over here. We're going to spin. I'm going to turn her head like that. Kent's going to pull out that thing. I'm expecting a gush of blood, which he's being very good about. And you notice the way I'm doing this again, if I can get it. She's going to behave. Maybe, maybe not. There we go. Is holding it again like a dart. This is the best tip I can give you about using cannulas because most people try to do it by holding it the way they're going to inject. It's difficult to get that angle. And now I'm flattening out the plane of the way I'm going. You see? I'm angling my hand down back underneath the skin, and I start the flow of product immediately from the base of my thumb, very gently, and I'm pushing forward. And what I'm doing over here is I'm trying to do a little coating underneath her skin, breaking up. Look at all those little pops, you see?
Sounds like bubble wrap.
Right. Each one of those little wrinkles has to be released. Okay, what happens is when she smiles, you can smile now or try to smile with anything. When she smiles, she breaks over here. There's an invagination of the dermis over there, and it starts to thin the dermis over there and get a little bit of scar tissue underneath that holds it down. So we have to release that, and this is what we do.
In Western Canada, we call this fracking.
Yeah.
So it's a way of breaking up structure, and then you inject the product to smooth and also stimulate elastin and collagen and that lattice network.
You could, but I usually don't because my tendency is that my cannula sometimes when I'm doing this, I mean, I consider myself an average injector, but sometimes my cannula will dip down a little bit deeper, and the risorius muscle is right here. The risorius muscle is coming off the fascia of the parotid and the masseter over here and working across. And if you nail that muscle with toxin, you're going to have a problem because it's a very thin muscle. It has a sparse number of neuromuscular junctions, and once you obliterate them, it takes a long time for that muscle to recover. Where you get about a 3 or 4 month duration here with toxin, you'll get 6 to 8 months duration here, and they won't be able to pull their lip out at all when they smile. They get a very narrow little sort of small mouth smile, so you got to be very careful.
It's particularly a problem if you're doing masseters, because that muscle is right
absolutely, which we didn't do and we should show.
So when you're doing masseters, make sure you do like 3 zones, but that anterior zone, you must keep it back about at least a centimeter back from the anterior border, because if you leak a little bit into the risorius, your patient will come and kick your windows in.
Literally. It can be, but that's why I have a little bit of epinephrine in the product as well. There's no question that high bruise areas are here, and in this area over here too. And then Kent was mentioning there's just a minefield of little vessels around over here too. So you got to be careful. Changing the direction on the cannula can be a little bit tricky. You have to come out almost, use your smart hand to see where the tip of the cannula is, but you have to come out almost all the way, because if you try to change direction when the cannula is half in, it's going to bend and cant like that. That's when you'll bruise them, because the cant will force the needle down into the vessels, okay?
Arthur's being modest. I mean, he's an amazing injector. But for most of you, I would recommend, if you're using a 27-gauge cannula, use a 25 trocar for 3 reasons. One is it's easier to find the hole. The second is that if you're going to go back a half hour later and touch that up, you can still see the hole. The third reason is if you're doing radial type of injections, for instance, if you're doing the jaw angle and you want, as you just did there, change directions, it's sometimes harder to change direction if you've got the same size trocar hole as your cannula. So personally, I'm not as good as an injector. I use a bigger trocar. So those are the 3 reasons I do.
Do you think that using the cannula affects the longevity? I find that I think the subcision enhances the results in my patients.
I think you can do it without any product, and you'll probably enhance the results.
Oh, yeah. We used to do that all the time with subcision for acne scars and for creases and lines like this.
They have arnica gel.
This is not new. This is just sort of
a little bit right
reinventing the wheel a little bit.
What dose of Botox do you use in your Mesonex for Crohn's?
Say that again?
What depth? What?
Okay, so let's figure this out. Rather than me telling you the answer of what I do, because it might be right or wrong, let me ask you a question. If you were to go ahead and to fill this area, which I will do on her, okay? I'm going to do this on her, and I'm going to do what you tell me to do, okay? So hopefully you'll tell me what I agree with, okay? Or that she'll tell me. If I'm treating this area over here, how much product do you think I need over there just because I'm coating under the skin? You don't want to make her all puffy and everything, so give me a volume. Do you think it's 0.1, 0.2, 0.3, 0.4? 0.2. Perfect. I agree with that 100%. What would you normally use as toxin over here, Botox or Xeomin? What would your Botox or Xeomin units do over here? How many units? Give me a big smile. Ilona, give me a big smile. For this whole area, what are you talking about? 10 to 12? Okay, so let's put 10 to 12 units.
Remember, we call it crow's feet, but some patients it's hummingbird's feet, some people it's blackbird's feet, some people it's crow's feet, some it's ravens, some it's eagles, and some got buzzard's feet. So it depends on how extensive that fan muscle is how much you use and what you do.
Okay.
So, but you've got to be really careful with the Zygomaticus major because she's a smiler. So if you watched her when I was doing my demo there and I told her a dumb joke to give her a spontaneous smile, she uses her Zygomaticus major to smile. So if you happen to and inject, smile for me dear, to tell you something dumb. See, if you inject this bottom part of her crow's feet here, you'll hit the Zygomaticus major and she'll also come and kick your windows in.
Right. Zygomaticus major over here, you can sometimes target that. Remember that the orbicularis muscle over here is a cheek elevator as well. Not just a constrictor for the eye, but it's a cheek elevator. And if you go ahead and you blast the orbicularis to the point that it doesn't move, she'll pull with her zygomaticus more and her zygomaticus here and her levator of her lip, and she'll smile medially but not laterally. And patients will come back and say, my smile is different. I have a bunching of my cheek in the middle. That's because you've inactivated the orbicularis too much. So what I'm doing now is I'm taking out my toxin. Here we go. I'm a 1-to-1 reconstitutor, meaning that I put 1 cc for every 100 units of Botox. I put 1.2 for every 300 units of Dysport. And that means that in Botox's case, each little bar on this little BD2 needle is going to represent one single unit. It gives me hyper-concentrated stuff, and I'm able to put it in when I want to do brow lifts and things. I'll reconstitute it to 2.5 if I'm doing things that are more spreading for necks or for foreheads and stuff. So I change my reconstitution according to what I want. But I did it here just to show you that I'm going to draw up very carefully over here. When you do this, don't touch the bottom of the vial, because you'll dull those needles out very rapidly. I now have, as you can see over here, I have 11 units. Okay? Because somebody said 10, somebody said 12. I decided to go with the average. I'm going to take my reconstituted Volbella that's on a cannula over here. This is looks like a 30 gauge cannula. Let me have a 27 gauge, please. Do you have the cap for this? Yeah, this is
This isn't off-label. This is out of the hotel.
It is. But that's what you guys are here for, is to see the crazy stuff that we do, right? So here it is. Here's my Volbella mix. So I already have off-label mixed Volbella here. That's 50/50.
So I said it's out of the hotel.
Right?
It's not even close to on
I
label.
withdraw a little bit over here, like that. Put a little gap, and then I'm going to go onto the top over here, and I'm going to take my Botox. This is really crazy, guys. And we're going to inject the Botox into the product. Okay?
I would
What did I say?
I would suggest that 99% of you don't do this. So I'm serious, until you've had 10,000 hours of injection.
Okay.
And then
Let me have a 1 cc.
Because all this looks very easy. But
for those of you who are expert,
I inherit challenges. In fact, my clinic, I don't hardly see normal patients. I see mostly challenges created by somebody from Walmart and that's had a weekend course somewhere and thinks they're Michelangelo on Monday.
I've now connected that to a blank 1 cc syringe. My toxin, you can still see it here because there's no bubbles there. And now I'm going to do this. Am I blending it perfectly evenly? I don't know. There's no medical evidence to show that it does that. I can only tell you what empirically has happened, or clinically, objectively, what has happened, or I should say more even subjectively, what has happened in my practice is that I started doing this. I started seeing results that were 40-50% better than what I was able to accomplish before. Okay, so now I have those 11 units blended into a 50-50 blend of Volbella. Okay, there it is. I'm going to put it on a 27 gauge cannula. Why not a 30? I could, but what's the risk over here? Bruising. What's her situation? Her situation that she has blood thinners on board. And what I'm going to try to do is I'm going to try to coat this entire area over here. So we're going to come at an approach. Can I have a dry sponge, please? Or a sponge that has a little bit of chlorhexidine on it, whatever. Just so I can keep something here in case. Thank you. There's our little chlorhexidine sponge. We've got it.
And we're talking about this chlorhexidine. It's a little bit...
you got 27?
27.
Thank you.
I mean, we're not doing Billy Bob's bubble car wash with chlorhexidine. We're doing tiny bits and not using lots of products. So it's, yeah.
Go ahead. There we go.
So you're not bathing in it. You're
flatten. Got it? I'm pressing against her skin, which is why you make sure that the skin has been cleaned beforehand, which I did with the product. And now I'm going to gently go. Look, I'm not even putting any product in. Look at the plane that I'm in over here, okay? I have to be in the subdermal plane. It's going to be a little bit sensitive here. Atta girl. Because I'm breaking up those little adhesive bands. And I'm just going back and forth. I'm going to go a little more superficial here.
You think of them like little speed bumps.
And I'm not afraid, because I'm in a superficial plane over here, I'm not afraid to go over the zygomaticus because I'm staying very superficial. Right here, look. Okay? And I'm going to coat that area over here too.
It gets right in there. That's the ophthalmic ligament there, and it's a little bit of a bump there. I usually tell my patients it's like breaking up the septi and the grapefruit sections.
Since you're using Botox Mesonex, are you saying a centimeter outside of the orbital rim?
Yeah, you can, but that centimeter outside the orbital rim has never deterred me before if I'm injecting superficially. If you're injecting down deep over here, you have to be careful because then you can pick up lateral rectus of the eye and you'll cause a diplopia. But when I inject my Botox, if I'm doing pure Botox or Dysport or Xeomin injections into this area over here, my injections are intradermal wheels. And then I wheel and mash. I do not want to go underneath the skin because I'm right on top of all those little blood vessels right now. And I'm just very happy that I have not caused a major bruise to her yet. Notice I said
right up high where he's at, there's epidermis and dermis. It sits right on orbicularis. There's no subcutaneous fat there. So that's why you can be so shallow and hit the orbicularis.
I will not do, and somebody asked me that yesterday, and it's a very good point, is the fact that I will not use this blend here, because to use a combination of filler and toxin under the eyes, I think, is asking for trouble. The filler is going to try to draw in water. The toxin is going to decrease the action of the lymphatics and the muscle pumping action to drain the area. So I find that if I do a combination at the same sitting, very often patients will start to develop some swelling or festooning. So what we want to do is you want to treat one or the other. I'll do toxin first, bring the patient back 2-3 weeks later and put in filler. I'll do filler first, bring the patient back a couple of weeks later and do toxin. But I don't like to use the blend over there. Okay, so you see the superficiality of it. I'm not killing her now. And I can get a little more aggressive after I've put in some stuff because of the fact that she already has anesthetic in there now. So she's not squinting or doing anything like that now. And just to show you where the orbital rim is, it's right here. And there's the tip of my cannula. Do you see it? Okay. Now I'm going to go ahead.
Probably want some more of that.
And we're going to just gently blend that in. We're going to sit her up in a second, but I'm going to do what I call now the Don Lalone shake. Shake, rattle, and roll. We're going to put it in over here, Don, okay? Because I know that you were going to ask me for that. Can I have the Voluma, please?
Straight up.
Oh, you can give it to me already mixed. That's perfect. What do I have there? Yep, that's fine. No problem. Okay. Pull it out. So remember, what we're looking at over here is this is the area that we want to pull and give her a nice little jawline contour. She's doing pretty well, as Kent told us about at the beginning. What I'm going to do is I'm going to go ahead and I'm going to lift the skin up and let it fall back onto the needle. I'm going to lift the needle up and I'm going to put in a small bolus. Those boluses are literally 0.05, so they're half of a 0.1 bolus. I'm going to do this for a number. I used to do this with a cannula. I think when you use a cannula over here, you're contouring. But when you do this, it's almost like you're tacking, okay? And then I'll do another row maybe just above over here. Be artistic about it. There's no paint-by-numbers situation about this, okay? But she's being very, very good. Okay, I started off with 0.75. I'm now down to 0.3, so I've put it in 0.45. I'm going to take a little bit of the arnica gel. That's also blended because her skin is thin, but I would normally use straight up. When you put the arnica on, put it on the back of your hand so you don't contaminate that for the next patient. Okay? If you're using ultrasound gel, the same thing. And as Ken said, be light-handed. You can see the difference already, can't you? Okay. I used on here, my typical amount is 0.4. 0.4 in 0.05 increments, so there's 8 little injections that I do. But it's not a formula, guys. You'll decide, if it's a patient who needs a little more volume over there, you can use a cc or 3/4 of a cc. Be artistic about it.
Any reason you wouldn't go under the masseter?
You can. I mean deep? Okay, so what the story is, there are a lot of excellent injectors who inject deep under the masseter over here, but that masseter is a huge muscle. It's the strongest muscle in your body. The amount of torque that you can develop with the bite is much stronger than anything else that you can do. So that muscle is really, really solid in there. And I understand when people go down on the bone, they have to try to elevate both the muscle, the tissues over it, the parotid and everything. So for the type of thing that I'm doing skin redraping, really. I'm not doing a contouring. But for contouring, you can certainly go down onto the bone. Some people use cannulas. Some people use needles. Whatever you're comfortable with, that's fine. Understanding that the artery is where? Centimeter anterior to it, and the vein is 1 centimeter behind it into the actual front part of the masseter. What do you think, guys? Can you smile for me, please? Show me your teeth. Atta girl. Relax now. That's it. Okay?
It's tight, though.
That's what I want it to feel like, and it feels tight, which is a good thing. Okay? You can see the difference between the two sides, and Kent was saying that she was sleeping more on this side. You can see the difference in the two sides. And if you wanted to do the Fagan technique of chasing some of these little lines over here, but you can see how much she's not breaking here anymore as she is on this side over here. Okay? You can chase these little lines by using Bellotero Balance, using Restylane Silk, using Volbella if you want, and just trace out a line or two afterwards. That's what you would probably appreciate, but we're doing fine over here. So I'm good. I would. And you know, when I'm sorry, I'm going to have to ask you to put this back on again. Do you mind? Go right ahead.
1, 2.
You can't blend, you know, cannulas can't go intradermal. They shouldn't go intradermal. They hurt like hell if they go intradermal. They hurt when they scrape along periosteum and stuff. So we got to be careful about that.
You cannot inject blunt cannulas in the dermal.
Can I have the Voluma again on a fresh 30 gauge needle? What we're going to do now is I'm going to actually use Voluma into the mental crease over here, which is a little bit of a more sensitive area, but she's a good patient. I think she'll be able to tolerate quite well. I'm also going to do a little injection over here, okay, just to blunt out that corner. Put your chin up, and I'm going to turn you a little bit, okay? I want to see if I can just blunt out this little corner over here. That would be nice. And we're going to do this. We're going to do this. When you inject into this area over here, what you're trying to do is do this. And so what I'm going to try to do is actually soften what Kent so affectionately referred to as a witch's chin, which is the point of your chin over here. I'm going to try to soften that a little bit so that she's not so deep over here, and I give her more length over here, okay? So let's have that. This is Voluma. Great. So here we go. I'm going to retract the nose away. Let me see if you guys can see this. You can. Okay. You're going to feel a small stick.
It's going to hurt a little bit.
There it is. I'm in. Okay? I'm injecting on bone. I have to feel the bone. I must feel the bone or I do not press the plunger. Where am I angled? What am I aiming for? Opposite commissure. Correct. Small injection, 0.05. We're at 0.1. Look how slow the plunger's moving. I'm looking here. I'm looking here. I'm looking in my rear view mirror. I'm looking where I'm driving.
I would advise most of you to lift up the nose at the same time.
There you go. Now we're going to do that.
To fill, because the filling creates lift.
Nice slow injection. And I rarely put in more than 0.2 or something. Okay? There we go. You can almost see that the nose is slightly canting to the left side now because we've elevated the tripod on this side over here and we've blunted out that angle. Do you see that? You can see the difference in this angle and you can see the difference in what's happening over here as well. Okay? You can see the narrowing of the nostril. Do you see how the nostril is narrower on this side than there is on this side? She's flared still on this side, but she's narrower over here. That's because we've elevated and we've pushed it in just a little bit like this. That shows you the ability of these products, especially a product like Voluma, or I use Ultra Plus here as well in the Allergan portfolio, to be able to do that. I'll do that on Asian patients, on Afro-American patients, and on Mediterranean patients that have very wide flared nostrils. This is how I bring the nostril in. You can't bring it in a lot, but you can definitely make a difference like I just did over here, okay? It's a much more aesthetic look, this. We like to see the nostrils more vertical than we do seeing them more flared out like that, okay? Good. Let me have that Voluma again, and I'll take it just for the little injection here, or we can use Ultra Plus if you have it. This is it. So what I'm going to do over here on this thing is I'm going to try to stay subdermal with a little needle injection. And I'm going to just give little teeny deposits over here. to see if I can use a little bit of the G prime and the cohesivity of the product. I'm in the subdermal plane, guys, okay? I'm not injecting this product into the dermis. I don't believe any of the Vycross products belong in the dermis. They have a little too high G prime for the dermis, and it's tough to blend them when you actually get them into the skin. So this is a multi-puncture technique. Could you do this with cannula? Sure you could. But to be honest with you, I'm sticking her multiple times because I want to stimulate as much collagen as I possibly can, even just with the needle sticks. And she's being very good and not bleeding very much.
He's being optimistic because that mental crease
is a killer.
It's tough to lift up.
And very often we have to do it in 2 layers. We have to do it subdermally and we have to do it a little bit deeper as well.
I usually tell patients those are good luck. You just kind of keep those.
I like that idea. That is going to be a 100% absolute yes for neuromodulator for her over here. Can you stick your lower lip out for me like this, Alona? Like this. Look what her mentalis is doing, okay? What her mentalis is doing is the mentalis muscle, as I was explaining to my friend Matthew in the other room before, the mentalis muscle takes its origin from right underneath the mental crease. It takes its origin from there, and then it comes up to the skin like a broccoli. See my hand over here? It does that. If you were to cut through the chin on a tangential angle, just snip off the chin like this, you'll see little muscle fibers in little bundles, all like this. And that's why we get that popley chin, the rugae that we get over there, right? So my treatment in toxin is to target exactly the way the muscle works. I put a central injection over here, usually moderately deep, in the midline, so I don't affect depressor labii inferioris. And I use 2 other injections over the maximal point. Can you stick your lip out again? I would put 2 other injections, 1 here and 1 here, maybe even a third one on her more superficially over here, into the dermis and subdermally. You got to remember that you have the DLI that's sitting right here, the depressor labii inferioris, and if you touch that muscle, she'll have an asymmetric smile. That depends. Kent?
I usually use anywhere total of 3 to 6.
Right. Of Botox units and the same thing.
A Botox equivalent kind of thing.
About 15 units.
And about a centimeter and a half or a finger breadth and a half a bit above the mandibular line underneath.
Okay, the last thing I'm going to do over here, we softened her a bit. She's not as deep. It's a little more evident because there's little red dots over there, but I think we softened her. Can I have a little bit of the arnica, please? I would definitely combine with neurotoxin when doing the chin here. And as Kent says, when you do this type of thing, if you're putting filler in, what do you call it, Kent, when you're running your hands over like this?
Rock and roll.
Rock and roll, I guess, yeah.
But gentle, just because it's a doll you're working on. So you got to feel the proprioception helps you determine areas that need attention, plus areas that'll blend and mold.
Now we have over here, I'm going to go ahead and go after her tear trough, and I'm going to show you the tear trough technique that I've been doing of late. This is again blended Volbella 50-50. Anytime I use product around the orbit over here, I prefer to use a 50-50 blend, whether you want saline or lidocaine in it, I don't care. The reason being is I'm trying to put in a wet sponge instead of a dry sponge, so the wet sponge already has the water that it's looking for. Okay? Again, I use the outside of the iris as my mark of understanding that I can go, or actually, can you open your eyes, please? Yeah. What you can do is you can use, the inside of the iris to tell you that up until the inside of the iris, from the medial canthus, the orbicularis muscle is stuck to bone. The rest of the muscle in the shape of aviator glasses over here, it's stuck to bone here too, but the rest of the muscle is gliding on top of the fat, the SOOF, and the roof. There's a little midline raphe over here. That's the one that I was poking through before. So when you contract your eyes tightly to squint, you don't do this. You do this. Got it? So it's a sphincter action. I don't want her to kick my product around. I can't get under her muscle over here. I'm going to be in it. Over here I can. So I start on the lateral aspect of it. She's got a minefield of little vessels here. I'm going to feel a small little stick. I'm on bone right now. You can see the amount of the needle that's out, and I put in a small deposit. Here I can put in a little bit of a bigger deposit, maybe 0.025, because I'm under the muscle, and I just tap it. And I'll continue along over here like that, a little bit like this. This was the old-fashioned technique, the way we used to do it. I still do it. I want to show you that this is still a way to do it. You can use a cannula over here as well. Okay? And we'll run it up over here towards Kane's triangle, as I call it. Because Michael always told us that this is a great little area to inject here, but it's full of little blood vessels. You've got to be careful. There we go. Okay? I'm going to definitely have to bruise her at some point because this just doesn't make sense. So we're going to hold a little pressure over here. And now what I'm going to do is take the same stuff, which you see over there. That's it. Next one. I'm going to do the same thing medially now, but I'm going to put in micro mounts. So if I used 0.25, which is half of the 0.5 here on the BD2, I'm going to use maybe 0.02. Okay? I'm going to continue along this way. Here we go. Small stick. If I don't feel the bone, I do not inject. That means that you're above the bone and possibly behind the orbital septum, and that's where you put a little deposit in, and the patient will, for her life, continue to swell. There we go. So I'm just putting in a little drops at the bottom over there to give myself a little bit of a product. Now I'm going to take the same thing on a 30 gauge. You have that stuff right there? That's it? Yeah. I think that's right. Okay. So we're going to hold just a little pressure over here.
Open your eyes for a minute.
Okay.
See this side.
Mm-hmm.
Open your eyes, sir.
Okay. So we're starting to, now you can see that she has this ridge. I haven't really gotten to there yet, but she has this ridge over here. She has the same thing over here. She's very prominent with a little, I'm going to try to coat over that just a little bit.
Show them how you.
But I want you to see something different.
Show them how you lifted her lateral canthus.
That's what I was just about to show you. Do you see?
On the right side.
Now this is a youthful look to the lateral canthal region. Do you see that? By putting in a small amount of product over here.
Lifted up the lateral canthus.
Again, guys, let's understand something over here. What we're trying to do is create that 5 to 10 degree upslope. But this is really not fair because there is lidocaine in the product, and the lidocaine is obviously having a myomodulator effect a little bit on perhaps the muscles that are pulling down over here, okay? But there's no question that when you rebalance it here, when you put some support underneath the orbicularis, again, it's almost like memory. The orbicularis is saying, hey, I remember that's the way that I used to feel when I was 20 years old, and starts to get that little upward tilt. Do you see it? I don't know if it shows for you guys. Does it show?
Yeah.
Yeah, it shows. Beautiful. Okay, so what we're going to do now is we're going to do the other layer of the sandwich. We're leaving the muscle alone medially, and what we're going to do is take a 27 gauge needle.
27 gauge needle. You don't need it like a trocar?
Yeah, like a trocar.
Okay.
And then I need, what's this? This is the lumen. It's too strong.
This is Volbella in there.
You can use this technique. I use cannulas for all of this rather than the needles. So there's other ways of doing it.
I used it all probably.
When we're using cannulas, instead of bumping through, you can do one trocar stick here and do medial and lateral as well, or you could come from the top here at an angle and fill this whole zone and fill this with the opposite way that he was doing. So it's another way of just remodeling that.
Now, Michael Kane does this with needles.
Right.
And that's the technique. I'm trying to see if I can just backload this. I've never tried to do this before. This is going to be, I can't do it that way. I'm sorry.
And needles are fine. It's just there's another way of doing it.
So what I'm going to do here, because I ought to do it properly, is the first thing we're going to do is we're going to clean the area over here again. I'm going to come in from the side. Okay, small little stick. And we're going to spin it and leave it there for a second or two. Let it tamponade. And we're going to take some of the Volbella, which we have over here. Okay? Let me have a little bit of the lidocaine, if you don't mind. I'm going to show you how I blend it. Okay? Because I like to blend things when it's... So I have a half a cc here of Volbella. You see that? This is pure. I could do it with pure, but I really want to take care on her because her skin, I can practically read a newspaper through her skin over here. You can really see the difference in what we've created over here from the two sides. And now, I'm going to take some xylocaine, 27 gauge needle, if we have. I'll take a 30 if I have to over here.
There's a 27.
Oh, even better. Thank you. Okay.
Yeah, yes, it's got a little anesthetic in it.
So let me have a 1 cc syringe, please.
It feels a little stiff because there's a anesthetic.
Right here. I have it. It's okay. This will work. Perfect. Okay. Here's a second 1 cc syringe. You got it? I'm drawing up 0.45 of lidocaine without epinephrine. Can I have the one with epi, please? There we go. Thank you. That's 1%, but it doesn't really make much of a difference, really. And then I'm putting another one over here. Now I have a half of a cc because I've taken that last 0.05 with a little bit of epinephrine, which is 1 in 100,000. Okay? And this is like being a witch here. You know, we're just sitting here over the cauldron, but I just want to show you something here. She's still smiling with the needle in her face. Okay. And then it's back and forth. Good. I'm going to put about 0.2 into this syringe over here. I rarely use more than that. I'm going to take a 30 gauge cannula. Okay? Why am I using a 30 gauge? It's a little sharper and I might bruise her, but I really want to have perfect control over the amount of product that I'm injecting over here. I'm going to ask Kent to remove that. This is a 30 gauge 1 inch cannula. I have to find that little hole. There she goes. Here's my little hole. I go into the hole and I flatten out the angle as soon as I go in, okay? I'm very gentle, just sort of like poking it gently up over here.
I can see.
I'm sorry, I needed to put stretch on the skin, though. Here we go. Okay? Very gently finding my happy space. There it is. Now look how superficial I am. You can practically see the color of the cannula. Am I going to inject with my thumb or the base of my thumb? Right. I'm going to go very gently back and forth like this. I'm going to turn her so you can see. And we're going to go back and forth in a windshield wiper with gentle pressure on it. She doesn't feel anything, I hope. And we're just going to fill in that area right there.
The idea of the windshield wiper concept a little bit is to create a little zone to inject rather than a little band. So if you get a little band of filler, it looks unsightly. We all inherit those patients. So you want to have a little, he's just freeing up a little zone to inject. But windshield wiper, I don't know if you can see that or not, where he's doing that little.
I'll try to do it from this angle so you guys can see here. But you see the superficiality of my needle over here. And she's got, I'm telling you, she has maybe 3 cells for her thickness of her skin here. Okay? No, if you lay the product very thin, you won't get Tyndall. Tyndall occurs because of thickness. You can do Tyndall with water if it's, like that's why the ocean is blue and it's very deep. Okay? I haven't even used, so I had 0.2 in there. I have 0.1 left. Can I have a little bit of the arnica gel, please? Thank you. And I'm gently going to just massage this just to make sure that you don't beat these products up. Whether you're using Volbella, whether you're using Restylane Silk, these are very delicate products and they weren't meant to be massaged. If you start to massage them, you bring in inflammatory cells. Those products have very, very fine little HA. There's a receptor on the mast cell called the CD44 receptor, which likes hyaluron, and she'll end up having her mast cells release and then get what we call either an angioedematous type of reaction if it's in a lip, or in her eyes, she's going to start to swell. You can open your eyes now? That's better. Okay? Still has a little bit of darkness there, but we can see right now that, put your chin down just a bit, we're going to look up into the camera, that we've taken out a lot of that. Now, I could go a little bit more.
This is 30 gauge.
It might be off.
Okay? She still has that very prominent orbital ridge here. I can go a little bit more, but I won't. This is the difficult part, is leaving the patient, allowing the patient to swell slightly to take out the rest. But certainly we have a rejuvenated side of the face over here with a 5 to 10 degree canthal tilt. And we've softened her tear trough area over here. We've optimized her cheeks. We've structured the lower part of her face by doing these injections. Look at the jawline over here compared to the jawline over there, okay? And we structured this part over here where she doesn't look like she's collapsing. We've also gone ahead and given her some structure over here. So I'll do the opposite side of the face now, and Kent can field questions from you guys if you have any.
What about the perimental hollow area? The perimental hollow, are you going to fill that?
The
Perimental hollow.
mental hollow. This area over here?
Yeah.
You're talking about the bottom of the marionette zone over here. I've already gotten to this one by doing it with the cannula when I was doing it before. I can definitely give her a little bit more boost over here. We might do that. We'll see. I'm looking at the position of her commissure here, and yeah, sure, we can probably just raise that up a little bit.
Finish the other side a little more balanced.
Okay, we'll try that and we'll see. But thank you for bringing that up. Maybe we'll do that. Yes. You can. I know Maurizio likes to do his CK1s and his TT1, 2, 3s, and we were just together in Europe, and he has his specific way of doing it. I don't, necessarily abide by the MD codes as he does. I'm a sort of a little more artistic thinking, but certainly you can follow his codes. They work very, very well. Okay, if you're up for that, that's perfectly fine. Voluma, okay. So give me that. I still have to do her forehead. Give me the Voluma, that's fine.
Yeah.
Sorry. When you're in King's Triangle and you're trying to lift the lateral canthus at 5 to 10 degrees, are you on bone with those bolus injections or are you in the
Yes.
Can I have the sponge, please?
Both. Because you want to just like Oscar was showing when he lifted up the triangle and put that little implant. It's the same way you inject the lateral commissure. You always start at the bottom of the pre-gel sulcus and then come up and eventually get above the red of the lip. Well, the same thing with the tilt of the canthus. You want about 5 to 10 degrees. So you'll inject, but you also inject on top periosteum, but you lift that at the same time. As you lift it so you have a little implant there. And I like the straight up products for most of these things. So I'll use straight up Voluma or Resti Lift or Refine. Refine's very good for there. But they also lift the tail of the brow the same way. So you've got to lift the tail of the brow. As you lift it up, as you inject, and as you lift that, inject the same time. And there's something magical that happens about that lifting creates a product that will actually help stay there. And then you repeat that again when they do their maintenance in usually 4 months. And you do a little bit, just keep it up a little bit and get that to lift back up. So it's kind of like a project. You have to just sort of see the dynamics of it. And it's like a teeter-totter out of balance. So you just rebalance the teeter-totter or rebalance the scales. So it's a combination of both. But he's using blended product primarily for trying to improve texture and contouring a little bit in lines and break those up and then stimulate a little bit of elastin tissue there. But if you're trying to lift structure, you got to have something that's going to lift. So the first part of the question was which product for tear trough?
Yeah, do you use Refine there because it's less?
You can, yeah. I can use Refine for tear troughs.
Nothing yet.
But tear troughs in this patient or that patient or this girl that's 20. No, it depends on what it depends on. That's why you have to look at the personality of the filler and the personality of the patient. I got patients that have tear troughs. You can park a smart car in there. So you have, and others it's very subtle. So it depends on what you're trying to create. But yes, you can use Refine. And but the only place I do a lot of blending is in the orbits and the lips. So even though I'm trying not to be cute, but it just got to depends on the scenario of what you're trying to create there.
Do you ever find that the multiple injections over the bonial angle where the masculinizes the feminine face?
So run that by me again.
The injections that you did here, do they ever square out and masculinize the face over the
No.
bonial angle?
You don't want to do that. You don't want to do that. It masculinizes the face by squaring them out at all.
Yeah.
And she was somewhat oval square, so you have to be careful. That's why I'm putting in just little aliquots of 0.05 each, because I'm not really going for volume here. I'm almost going for a tacking type of technique.
Yeah, you have to be careful you don't androgynize patients as well with that. Because you got to say, okay, what's masculine and what's feminine, and you got to try to. Most of the time, we're trying to make patients more feminine and guys more masculine, which is more male structure and masculine features. And you got to say, okay, what are those features? And that's kind of what you're trying to create.
Yesterday you mentioned sublingual Claritin for swelling. Is that?
I'm sorry, I can't see it out there. Okay, go ahead.
Oh, that's okay. Yesterday you had mentioned sublingual Claritin for swelling.
Yes, yeah. I use it a lot because it's basically a sublingual. It's fast acting. We use it for orbits and we use it for lips. And it definitely helps the swelling that happens a little bit in those areas for sure. So I like it. It's not a true sublingual, but it's basically you just pop the tablet out and suck it. It just dissolves. Canada has a little different name, but I think you have it here now too. It's basically a sublingual Claritin. Yeah, I use it usually if we're going to say, okay, this patient's going to have her lips done in 10 minutes, 15 minutes, then we give it to her. And if we have her orbits done, we're going to give it to her. That's the two places I use it generally.
You can buy a giant box at Costco of the Claritin.
Yeah, we keep them we keep each room in our clinic has them. We use them all the time. So they're good. I like them.
Very good.
So it's incredible what we can do with fillers.
Yes.
Neuromodulators, but I don't think we should lose sight of the fact that there are people that are better surgical candidates who can use this.
Oh yeah, no question. No question.
So can you help take us through from a examination standpoint the effect of the SMAS and the other muscles and when we really want to look for them first, as a primary treatment?
So I'll answer part of that as a plastic surgeon because obviously that occurs in my practice. I see obviously surgical candidates and non-surgical candidates. The first determining factor usually is the patient. I have patients who automatically say no surgery. So those patients I would send home 15, 20 years ago. Now I have an alternative that's not the identical thing to surgery, but I still have an alternative. In every case that I do a rhytidectomy, a cervical facial rhytidectomy, if I do a facelift, I'm always adding volume because we understand that it's not only a situation of lax skin, it's a situation of volume loss and contouring. So I do that with fat quite often during the surgery. And sometimes I even volumize a patient or recontour a patient with filler and then do a smaller procedure afterwards just to tighten the skin and tell them they're going to be on a maintenance of fillers for that. But you cannot blow up the balloon or you cannot blow up the face to take up all the wrinkles and all the sag. You blow up or you recontour or revolumize to ideal proportions using the calipers if you want or your eye, because most of you have the calipers in your head. You know how much you're supposed to do. And then you don't chase lines or sagging skin with volume. You chase contours and you chase ideal proportions with volume. And if there is a sagging element left after it, you have a choice. You have a choice of either using something that comes out of an energy box, the device. You can use Althera. You can use Thermage. You can use any of these venous lifts or things that you might have in your practice, which can give you maybe a 20% tightening. Or you have to refer the patient to somebody who will do an appropriate surgical procedure. So every patient is their own snowflake. You got to sort of decide that. You have just what you have to really do. How are we doing here? You're doing great, yeah. I'm trying to figure out how I'm doing.
I think it's important just to point out the effects of an aging SMAS or platysma and how that plays a role here.
For sure. I mean, with a lot of the treatments that we're actually doing, am I actually targeting anything in the SMAS? I kind of wonder what I was doing over here when I was putting in those needles that were sitting really, the SMAS is going to run from here to here. That's going to be the sort of the envelope in which the muscles are embedded. And we see that the platysma actually comes up and over, extends up and over when we do our dissections in the anatomy lab. It extends up and over the masseter and over the parotid as well. So there's a balancing situation that's happening. Some people believe, as in the Nefertiti lift, that if you go ahead and you put in toxin into the neck over here, that just like an eyebrow, that the cheek area should come up. I don't believe that happens, to be honest with you. I think what happens is you soften the muscle and it just lies flatter against the neck, and so it gives them a little more of a definition over here. I don't believe that there really is a counter vector type of thing happening. I might be wrong on that, but whatever that story is, it's a possibility. But there's no question that when we do our surgeries, we target the SMAS because it is a situation not so much of lengthening of the muscles, but of shrinking of the skull. And there's a relative lengthening of the muscles and the way that they act and of the SMAS. And if we don't do SMAS work at the time that we do the lift, then our lift has no longevity to it. If you just do a skin lift, the patient will look good for about a year, and then there's no elasticity there. It'll come back down again. So we target the SMAS. Some of these energy devices, like the Althera, which you can actually use the machine to see, I can actually identify the SMAS itself. You can see the fibrous band of the SMAS. You target it to try to shrink it a little bit. You get a little bit of tightening or shrinking in a vector, but that's about it. But there's no question that what we do here, people ask me, are you going to do a liquid facelift? There is no, to me, liquid facelift. What we're doing is we're doing some ideal contouring. We're doing some softening of lines. We're trying to bring back some natural expressions by using toxin to meter down the way that she's hyperactive in certain areas. And then you still got to do the surgery aspect of it. That's all there's to it. There's no question about it.
Dr. Swift has to leave at 12:30.
Yeah, 12 actually. So I'm going to, what do you got here?
You have to leave at 12?
Arthur, do you mind treating her mensalis, please, with a toxin? Are you going to do that?
Yeah, I'll do that.
Well, we're going to hold the questions for right now.
Do you have anything that I can use to filter out over here?
What do we got?
What's this?
Because we're on a little restraint.
For the radix and the dorsum of the nose, if I'm trying to create a very sharp top to the nose in a
She's talking about the dorsum.
Yeah, here.
Yeah.
But if you're talking about starting from the very top of the radix over here, going all the way down? Yeah. So for the radix, I want to use something that sticks together.
You got to lift it up.
So my product of choice on the Allergan products is Ultra Plus, because that's the most cohesive of all their products, and a little bit stiffness as well to it. My product of choice in the Restylane family would actually be Restylane Lift. Okay, or you can use Deep over here now if you're getting that.
But you don't want to use it down on the dorsum of the nose.
No, I'm talking about at the very top. Okay, when you get down over here, you want a softer product. For me, the thing to remember about nose is to understand that the anatomy of the nose has two parallel arteries over here in most cases, which are the dorsal arteries for the nose. There's an alar artery. Everywhere you see a crease, there's an artery. There's an angular artery over here as well. There's a whole complex of arteries that are sitting in the supratip area. And there is one artery that branches between the dorsal arteries that are heading up towards the supratrochlear, which is called the intercanthal artery. And that's the one that sometimes when you put your toxin in to go ahead and to do Procerus, if you're a little bit too deep, you get a drop of blood that comes back out. That's the artery that you hit.
See, she's had a rhinoplasty in the past too, so she's got some fairly altered tissue here, so you have to be really careful. But we'll finish up here.
So this, what I'm putting in right now, is the stuff that has the Meso-Mix in it, because you guys said we got to put in some toxin for her over here, so this is what I'm doing. You'll notice that on the other side, my entry point was below. Why is my entry point above on this side, guys? Sorry? That's right, because I'm right-handed. Absolutely right. I just do what's comfortable for me. In the old days, we used to make such big entry points that you'd leave a dot everywhere and you'd have to sort of hide them back in the hairline. But now you can go anywhere. You can pick any crow's foot you want to go ahead and go in. As long as you're comfortable, make it comfortable for yourself. You could imagine if I was trying to do it this way and demonstrate at the same time, it would be difficult. I very often switch hands as well when I'm doing that, like Kent does. I'm an ambidextrous type of injector, but that's because I was trained, as I said originally, in music on keyboard, so you get the idea of using both hands when you do things.
Can you talk about how you treat a tonic submandibular gland with toxin?
Yeah, we could. If you've got, remember, there's a parotid. Submandibular has a deep and a superficial part, and a sublingual gland. And the submandibular glands supply generally about 75% of the saliva. And most of my submandibular glands that I do, and I do probably 8 or 10 a day, literally, and none of those patients come for that. It's all serendipitous. Half of those have had facelifts. So the best facelift often exposes the submandibular gland. It's not that it's just more prolapse from the facelift. So I use anywhere from 8 to 10 units for the superficial prolapse submandibular gland of Botox equivalent. And there's reasons that I like one product over the other. We can discuss that at a different time, but that's generally what I use. And you don't want to destroy it. You're just trying to shrink it a bit. Otherwise, if you get dental caries, then that's another issue with stopping the saliva. And the tail of the parotid is easier to inject. You can be more assertive because there's not as much saliva coming even from these big ones. Tail of the parotid are extremely common. I saw at least 15 people here today that have the tail of the parotid. That's pretty obvious. And I also saw 12 people here that I counted that have collapsed nasal valves. And some of you know who they are and some of you don't. Anyway, the tail of the parotid, usually you inject, you can feel it, you get your fingers around the tail of the parotid. Where the submandibular gland, you can't get your hand around it. You can palpate it, but you can't get your finger around it. It's easier to expose the submandibular gland by putting the tongue on the roof of the mouth. Keep your mouth closed and push it. And you can usually see it exposed. So that's kind of and the tail of the parotid I'll use anywhere from, I think Waffles is using like 30 to 40 units per side of his parotids, right, Arthur? Yeah. So, you have to be a little bit careful, but I use a lot more than I used to. I use anywhere 25 to 30 units per side.
As I do.
Parotid. Is that what you use, Arthur?
Yes, I do.
Yeah. And that's a really nice concept because it really shrinks that hole, it makes that whole jaw angle, that occlusion angle much better and softer. So that's kind of my approach for that.
This is sensitive. I apologize.
And I don't charge for the units. We charge for the project. So those, I'm not expensive. I'm priceless. So I charge a little bit more for those. Usually, once you get those shrunk, they can last a long time. Sometimes they'll last a year. So once you shrink them down, I say, look, we'll see you in your 4 months for your maintenance, and then we'll re-inject it if we need to a little bit. Once you get it down, then they maintain pretty good, eh, Arthur?
They maintain for a long time, and I've yet to see a patient with xerostomia. I've yet to see a patient who ends up with a dry mouth.
Yeah, I very rarely see it. It's extremely rare unless you're being aggressive. But yeah, it's talked about, but it's really uncommon. So I don't think that's something you have to worry about too much.
Give me the arnica, please.
So he's gonna say how many units are you going to use on the neck for general use, right? Arthur, you're going to say how many units you're going to use, and he's going to say how much filler are you going to use on the neck. Figure those two together, and you add them together. You just add what you're going to use for the neck and what you'd use normally for the filler, and you use a filler that you want to use projection on the neck. No, you use a very fine filler, and you blend it. Then you add your neuromodulator. And you do like we've done. There's no cookbook for this. You have to go. And by the way, sleep's overrated. So
What's the typical mix?
the typical mix is 0.1 unit of Botox per microinjection, which is like a 20th of a cc or a 100th of a cc. And it takes my nurses about 6 months to learn how to do it, literally, because it's a micro injection that you do that's quite different. That's why I'm saying, don't do it until you've had some experience. Go to the literature and start with Waffle Wu's literature. He's got lots of photos. He's got some videos, and you can look at it and learn that way too. But it's not new, but you just have to think, okay, what would I use on a neck? Are you trying to treat necklace lines? Are you trying to treat the platysma bands? Or are you trying to treat the elasticity that's exaggerated from the platysma? Or what are you trying to treat? So then you say, okay, how much Botox would I use, or equivalent, Xeomin or Dysport? And then how much filler would I use on those necklace lines, for instance? And then you start, and you say, okay, where does the lower face and the neck start? It's like those photos I showed yesterday of the girl with that micro Botox. It's sort of the lower face and neck.
What was his name that you said that we could go read in Waffle?
Wu, W-U.
Waffles Wu. Yeah, W. He's a plastic surgeon in Singapore. You think we're off the wall. He's out of the country. He's fantastic.
Dr. Remington.
Yes.
Are you using PDO threads?
Pardon me?
Are you using PDO threads? Thread clear?
No. We went through the...
Contour thread.
Short answer is no. Advantages, disadvantage. I think in all these things that we do, you say, okay, what's the advantages of the disadvantages? And what's the disadvantages of the advantages? So when you look at all these things together, and that's how you come up, I think, with some of these things we do. And you got to remember, we've been around the block for a long time and seen that some of these things come and go. So it may have a role to play, and so in my hands, no, I don't use it. Short answer.
What do you have left? Give me whatever you have left. Perfect. Give me the Ultra.
But in this type of patient, normally, if this patient was in my clinic, I would start with laser. I would start with an erbium YAG laser and erase the wrinkles first. But I've got lots of patients like this I treat just with fillers. And I've got some patients that I would never dream that I could get good results with just fillers. But with some work and subcision and really working at it, you can do quite well. But normally, you want to erase wrinkles before you do fillers, generally. So we have lots of energy tightening devices, and I use a lot of erbium YAG laser, and we have 24 different laser lighter devices in my clinic. So some of our devices never turn off practically. So we use, and as I said yesterday, I average personally about 50 syringes of filler a day, and of some type of filler, and about 15 vials of neuromodulator. So, but you can't underestimate the power of energy devices and of all these things that go together, because it is the language of Combinese, after all. I mean, it's a separate language you have to learn, and of how these things all fit together. But in all honesty, we're trying to show you in a few hours here just a little microcosm of things that we do and don't do, and it's hard to tell you all the things we do and don't do.
What's that?
And it doesn't mean what we're doing, as Arthur keeps saying, it doesn't mean we're doing it right, because there's guidelines, not rules. So a lot of things we've done, we've learned that's a stupid idea, and we just sort of reverse and go back and say, gee, don't think it's a good idea. So there's 3 types of patients when you look in the mirror after. Patients who are visual. She paints and draws. Did she see it right off, Arthur? Right. Did she notice right off? Yeah, if you're a visual person, that's why I like to know if they paint or draw, because there's 3 types of patients that we look in the mirror after. The light switch is usually a visual person. Dimmer switch usually takes them a little while to look, and sunrise. So usually by tomorrow morning they'll see it in your patients that aren't very visual. Those are usually patients that don't decorate their own house, don't buy their own clothes. They're sort of not very visual type of people. Usually they're in my clinic, they're all accountants or lawyers. They're pretty vertical type people. They just don't see it. So she's a watercolor girl, so she probably saw it pretty quick. You see it? Did you see improvement there when you looked in the mirror?
Me too.
Yeah. So and if you paint the right picture, because your aim is just improvement, and it's a step. And it's a step. She didn't get this way yesterday, so she's not going to look a lot better by just one session. It's going to take a while. So he's done.
She just asked me if I did the same thing on both sides, or is she going to list to one side, she's going to tilt. I said, you'll probably walk around like that, and I'll know what I forgot to do.
Can you use cannulas for the necklace knots?
I haven't, and I'm back doing with just with needles now, and we use those German dose savers so they don't drip and leak all over the place, and a 32 gauge needle, half-inch needle, and if anybody has questions, just send it to Bob Rouleau, and he'll answer everything. Or he'll forward it to me or to Arthur, and I'm happy to answer anything. I'm happy to share anything. I don't have any secrets.